students, now we are on a very important long question, and this reads like this: describe the urinary bladder. So we are in the pelvic cavity, the lesser pelvis, and dealing with the viscera of the lesser pelvis. So this question is like this: describe the urinary bladder under the following heads. Okay, introduction of the urinary bladder. Okay, with some functions of it we will just deal, and then the external features. Okay, we will just learn about its borders, surfaces in the external features. Okay, and we will learn about its relation with the peritoneum. Okay, and then the third point is the relations. Okay, so we will learn about what are the visceras which are related in front, behind, superiorly and inferiorly with the urinary bladder. Then we will learn in the fourth point about the blood supply. The blood supply means the arterial supply and the venous drainage. We will just deal lymphatic drainage of the urinary bladder, and lastly we will come to the applied anatomy of the urinary bladder, which is the important. Okay, for learning to the applied anatomy we will have also to deal with the mechanism of the micturition. Okay, so this is an important question, a long question, so please sit with your notebook, pencils, color pencils, and keep on noting with me. Okay, some of the diagrams I have already drawn, just to, otherwise it will take much more time. So I have drawn and colored the diagrams already, so it will take the short time. Otherwise this video is going to be a long video. Okay, let us come to the answer, and the first point in the answer is the introduction of the urinary bladder. Okay, so when you see the introduction of the urinary bladder, you may write few sentences in introduction like this: that it is a hollow muscular organ. It is a bag, okay, in which the urine is filled. Okay, so it is a hollow muscular organ which is lying anteriorly in the pelvis. In this diagram, see, this is the lesser pelvis. Okay, this part. Okay, this is the lesser pelvis where pelvic viscera are located. This is the pubic symphysis, urinary bladder. This is seminal vesicle, and at the lower end of the urinary bladder, this is the prostate. So this is the prostatic urethra, which will become membranous urethra and will become the penile urethra. This is the seminal vesicle, which is placed posterior to the urinary bladder. This is the rectum, and this terminal part of the GIT tract is that of the anus, anal canal, and this is the sacrum and coccyx. So it is, and this blue color thing indicate that this is the peritoneum covering to the pelvic viscera. Okay, pelvic viscera. So this is that about the orientation of the pelvic viscera, in which we are dealing with the urinary bladder, which is placed most anteriorly, okay, in the pelvic cavity. Now this is urinary bladder, as I said, is a muscular bag, and thus it stores the urine in it. Okay, so it is a temporary storehouse. Why temporary storehouse? Because, okay, after few hours we have to empty this urine which is filled in this, okay, in the urinary bladder. So this is a temporary storehouse of the urine. Urine comes from the kidney, gets collected here, and with the regular intervals it is get emptied. Okay, now the capacity of this urinary bladder is about 200 milliliter, or more than, little more than 200 milliliter. Okay, and after that one feels to micturate, okay, to pass out the urine, and then he goes for the passing the urine after collection of this much of the urine within the urinary bladder, which is a muscular organ. If you see the location in detail, okay, of this urinary bladder into the true pelvis or the lesser pelvis, okay, this is an organ which is just behind that of the pubic symphysis. Okay, pubic symphysis, and this is lying anterior to the rectum. Okay, it is lying anterior to the rectum. Okay, it is its capacity, if you see, okay, it usually about 250 milliliter of urine when gets collected in this. Okay, then the person feels, okay, has to go, not only feels, but he usually goes for the micturition or passing the urine. And when it is more than that, okay, then the bladder start expanding. Okay, it becomes full, and then it it expand upward, because there is no room to go towards the pubic symphysis or posteriorly towards the rectum or inferiorly towards the the perineum. Okay, this is the urogenital diaphragm is here. Okay, sphincter urethrae muscle is here. It cannot go lower down, so only place where it can expand is upward. Okay, so the bladder becomes large and large with the collection of the urine. Okay, with the collection of the a person can tolerate the collection of the urine up to 500 milliliter, after which it will become very painful and one has to pass the urine. Okay, one has to pass, so that when it is more urine is collected in this urinary bladder, okay, this becomes an abdominal organ. It is pushing to the peritoneum, which is covering to its superior surface, and it become an abdominal organ, so that its lateral surface or anterior border comes in contact with that of the anterior abdominal wall. Okay, anterior abdominal wall. So in a dilated urinary bladder, one can go inside the urinary bladder by giving a surgical incision in the lowermost part of the anterior abdominal wall without just interfering with the peritoneal cavity. So the anterior infralateral surface of the bladder becomes it comes in contact with the anterior abdominal wall. Okay, so this is about the introduction of the urinary bladder. Okay, let us now come to the second point. So we have covered almost the introduction of the urinary bladder, its location in the pelvic cavity and its capacities, and when you feel the desire to micturate, or when it becomes an abdominal. Okay, it expand towards the abdominal cavity. Now let us come to the second point, and that is the external feature. Okay, now when urinary bladder is empty, okay, when urinary bladder is empty, it is tetrahedral in shape. Okay, this is the urinary bladder, and you can see it has many surfaces, and almost all surfaces are triangular in shape. See this? Say for example, it is superior, it is lateral, it is posterior, and all surfaces are triangular in shape, and this shape is called as tetrahedral shape. Tetra. And if you have seen a samosa, an Indian snack, okay, that is also tetrahedral in shape. Thus a urinary bladder resembles to the shape of the samosa. Okay, so this is a tetrahedral shape when, of course, it is empty. Okay, when it is empty, then it has tetrahedral, but when it will be full, okay, it will have only two surfaces. When it is full, that means when it is more than 200 and 250 milliliter and still more 350 comes, its shapes, all tetrahedral shapes gets distorted, and then it will have only two surfaces, an anterior and a posterior surface. Okay, anterior, and it become oval in shape. Okay, these borders and surfaces, they are lost. Okay, they are mostly lost, and just it has an oval shape. So let us see first what is tetrahedral shape and what are the surfaces and borders of an empty bladder. That you should keep in mind. This is, we are talking of the external features, and we will talk later on relation, and that is in relation to that of the empty bladder. Okay, so there is an apex of this empty bladder. This is the apex. I will just write down here. Most of the thing I have already written to save the time. This is an apex. That means apex in this position will lie here, just posterior to the upper margin of the pubic symphysis. This is the apex of the urinary bladder. So this is the apex of the urinary bladder, and since it is the apex, naturally opposite to it will lie the base. So this portion, so this is the anterior side towards the pubic symphysis, and this is posterior side towards the sacrum and coccyx, that means towards the rectum. So this is the posterior aspect, this is anterior aspect. So this naturally opposite to the apex will be base. So this surface, which is also triangular, it is called as base, and sometime to this surface you call it as posterior surface, to the base. Okay, so it is also called as posterior surface. So this triangular surface is the base. Okay, now then there is a neck. See here lower down, okay, inferiorly there is a presence of the neck, and from the neck, okay, at the neck there is an organ which is surrounding to the urethra, which is starting from the neck of the urinary bladder. This is called as prostate gland, which completely surrounded the first part of the urethra, that is called as prostatic urethra. So this gland is called as prostate, which completely surrounded. That means it abuts onto the neck of the urinary bladder. So this lower part here, where I am just putting my pencil, this part is called as the neck, which is fixed and a firm part. Okay, neck. Okay, now so after seeing the apex, the base and the neck, let us see the surfaces. Let us see the surfaces. And if you will see the surfaces, there are the three surfaces. This is called as the superior surface. Superior. Okay, this is the superior surface. As I said, all surfaces are triangular. That's why the shape is tetrahedral. Okay, superior surface. Then this is the right and left infralateral surface. So this is the left side. The opposite side, which is not seen, will be the right side. So it is the left infralateral. Just I am writing here on chart. Infralateral. So this, since it is a mid-sagittal section passing through the pelvic cavity, in this you cannot see. You are seeing the inside of the bladder, but this surface is the one left infralateral, the other will be then the right infralateral surface. So right and left infralateral surface, they are the I mean to say on right side and the left side. And sometimes this is not called as infralateral, but it is simply called as the lateral surface. So remember that either you call it as infralateral. Why it is infralateral? Because it is slightly looking towards the inferior side, not only lateral but slightly towards inferior, because the pelvic cavity is tilted, okay, forward, okay, and this bladder looks onto the inferior surface. That surface looks slightly onto the infralateral side. That's why it is called as infralateral, or simply the lateral surface. Okay, so how many surfaces you have learned? In three: one superior, one right infralateral, another left infralateral, and another base. You can also call it as posterior surface. If you are calling the base as a posterior surface, then there are four surfaces. Okay, one superior, two lateral, and one posterior surface. Okay, one posterior or base. Okay, so all these surfaces, as I said, they are triangular in shape. Okay. Now, because of this triangular nature of the organ itself, as well as the all surfaces are triangular, there are four borders. Let us come to see the borders. Okay. In this, you can see the borders. These are the two lateral border coming from apex towards the base. These are the left lateral border. Left border, okay, lateral border, and this is the right lateral border, okay. And then there is one border which is going from apex towards the neck. See here in midline, which is in the near the median plane or exactly in the midline. Okay, this border is called as the anterior border. This is called as the anterior border and sometimes antero-inferior border. So you call it as anterior border. Okay, and then there is one posterior border. This border, see this? This border is the posterior border, which is limiting it on the superior surface. That means this posterior border is present. Let me write it here. Posterior border. Just simply, this is the lateral border and this is the anterior border. Anterior border. So anterior border, two lateral borders and one posterior border, and one posterior border is here. So these are the various borders here. So let me just describe the posterior border, which intervene or it is placed between superior surface and the base, or the posterior surface is posterior border, and between superior surface and infralateral surfaces, this is the right and the left and the right lateral border. Okay, and then this is the anterior border, which is in midline. Okay, in midline. Okay, so between the base or the posterior surface and lateral surface, it is mostly rounded. There is no distinct border is present. That's why there are only three borders are there, two lateral and one posterior, and four borders and one anterior border. I hope you have understood. Now at the junction of the lateral border, right and left, along with the posterior border, here is the entrance of a tube that is called as ureter. Okay, so here this right and left ureters are here. See, this is ureter and this is also ureter. They enter inside the urinary bladder. Okay, they are bringing the urine from the kidney, okay, and emptying it into this muscular bag. So these are the two ureters which are placed at the base of uppermost portion of the base or posterior surface of the urinary bladder, while the anterior or apex is connected with a ligament which I have shown you here in green color. It is the median umbilical ligament. Okay, it is median umbilical ligament, which is a fibrous band from apex extending right up to the umbilicus. Okay, it is umbilicus. This is a remnant part of the urachus, okay, which is the continuity of the this vesico-urethral pouch or vesico-urethral tube, which is having a communication to the umbilicus, okay, through the urachus. And this urachus, which is a tubular structure extending up to the umbilicus, that gets obliterated, okay, and then it forms a median umbilical ligament. So from apex to the umbilicus, this is a ligament, fibrous band, which is called as median umbilical ligament. And at the neck, I have shown you that this is the prostate. I hope that you have understood the borders and surfaces of the urinary bladder. Let us now come to the relation of these surfaces, okay? Various surfaces, relation of the various surfaces. Okay, so we come to the relations, and in relation what we will see first, the relation of the apex. Okay, this is the apex, and let us see the relation. You keep on noting, okay? So we are on the third point, that is the relation. So this was the second point. We have covered first, second, and we are now on to the relation. So relation of the various surfaces. Apex, how apex is related with the median umbilical ligament, which I have already told you, it is an obliterated urachus. Okay, when you will learn the development of the bladder, then you will learn the significance of the obliterated urachus or the median umbilical ligament. Let us come to the relation of the base. And where is the base located? It is nothing but the posterior surface. Above it is between the opening of the two ureters, which are coming from right and left kidneys, and here lower down where there is the apex of the posterior surface, it is the neck of the bladder which is in continuity with that of the prostate gland. So we are now learning the relation of the base, okay, of the base. See here, this I have drawn from the posterior aspect. Sitting here in front of the rectum, for example, we are looking towards this surface which is the base or the posterior surface of the bladder. So whole thing is the base. This is the base or the posterior surface of the urinary bladder which we are seeing from behind. So this is, as I said, all surfaces are triangular. This is also triangular. This is the posterior border is here, and this is an indistinct rounded borders which are continuous with that of the lateral, infralateral surface on either side, right side as well as onto the left side. Now, in this base is related to many important structure, okay, the posterior surface. First thing is that the whole surface, the base, the whole surface of the base is separated from the rectum. It is separated by a condensation of the loose connective tissue which become condensed to form rectovesical fascia. Rectovesical fascia means between the rectum and vesicle means bladder. So between the bladder and rectum this facial septum is present, called as the rectovesical fascia. And how it is formed? It is formed just by condensation of the pelvic loose connective tissue and to form a facial like structure. So this is the rectovesical fascia, okay. Now I mean to say this is also related here, okay, with the I mean to say peritoneum. If you will see the relation of peritoneum, this part of the upper part, okay, the upper part of the posterior surface is covered by the peritoneum. It is covered by the peritoneum, very small part, okay, of the posterior surface or base is covered by peritoneum. So see here the relation. Peritoneum, after covering to the anterior abdominal wall posterior surface, it will reflect onto the superior surface of the bladder. Then it will form a covering onto the upper part of the posterior surface or the base, and then from there it will reflect backward onto the rectum. Okay, first it will cover the anterior surface, then lateral surface, and then it will go posteriorly. So there is a pouch-like structure is formed here when this peritoneum is reflecting from the base, upper border of the base of the urinary bladder to the rectum, and this pouch here is called as rectovesical pouch. So this forms a pouch here, so that is called as rectovesical pouch. I am writing here rectovesical pouch, okay. So this is the rectovesical pouch, and in this rectovesical pouch, this part of the the base comes in contact with the coils of the small intestine. Okay, so the coils of a small intestine or sigmoid colon is in relation to this surface. Okay. Now, other relation, okay, which is not covered by peritoneum. See this, the whole of this posterior surface is not covered by the peritoneum, okay. So, this is in relation with the two important structure. This is the seminal vesicles, okay. These are the right and left seminal vesicle is here, okay. And then this tube which is coming here, okay, this is the vas deferens which become this crumpled here, okay, dilated, more dilated as compared to its regular lumen or regular diameter, and then it unites with the seminal vesicle duct, and both the ductus deferens and seminal vesicle, they form the ejaculatory duct after union. So these are two ejaculatory ducts. So these two structure and the opening of the ureter. So many important structure, and while the ureter is going inside the urinary bladder, penetrating the base here, it is just comes in relation superiorly with that of the vas deferens. Okay, this is which is bringing the sperm from the testes. Okay, so this is the vas deferens. See this relation between ureter and vas deferens, and how the ejaculatory duct is formed which penetrates the prostate. Okay, all this structure they lie in relation to that of the posterior surface. I hope that you have understood the posterior surface. This is the case of the male where seminal vesicle and vas deferens are present. Now what is the case in female? How the posterior surface is related to the female? There is no vas deferens, there is no seminal vesicle is here, there is no prostate in the female. So this posterior surface, okay, and that rectovesical pouch, or that means that much area is also not covered by the peritoneum in case of the female. So there is nothing, a deep rectovesical pouch formed by the reflection of peritoneum is also not seen in case of female. So female, in case of female, this base or the posterior surface is related to the cervical part of the uterus, that is cervix of the uterus, and the lower part is related to that of the vagina. So what lies posteriorly here? It is the vagina and cervix of the uterus that is related. The body of the uterus is not related, okay, because it comes superior to that of the superior surface of the urinary bladder. So this was the relation of the female, that is vagina and cervix. Okay, let us come to an relation of the neck, and I said the neck is the lowest part, narrow part of the urinary bladder, which is inferiorly. It is the lowest, but it is a fixed part. It is attached with the ligaments. Okay, as I will tell you in relation also of the neck, the various ligaments are attached here to the lower part. And this lies about 2 to 3 centimeter behind pubic symphysis at the lower margin. See this is the pubic symphysis, and about 2 to 3 centimeter behind and inferiorly, this is the neck which is situated. Okay, so you should remember that this distance between pubic symphysis and behind this lower margin of pubic symphysis, about 2 to 3 centimeter is the neck, and here this neck, okay, at the in the neck region there is the presence of the circular band of the smooth muscle. Okay, this place, circular band of the smooth muscle is present, and this will form a sphincter. So the lowest part of the urinary bladder at the neck is identified with the presence of a circular band of the smooth muscle, which is called as the pre-urethral sphincter or internal urethral sphincter. Okay, that means contraction of this band of the smooth muscle which forms the sphincter will close the opening of the urinary bladder at the neck. Okay, so this is the pre-urethral sphincter. Okay, and the neck is related, as I seen here in this diagram, this neck is related to the prostate in male. Okay, in case of, because there is no prostate in female, so it is directly resting onto the prostate. That means the neck is related. Okay, but in case of the female, since there is no prostate, it is related to the pelvic fascia. Okay, here will be the pelvic fascia, neck will rest on the pelvic fascia, okay, which will ultimately is still lower down will be the urogenital septum, that is the sphincteric external urethral sphincter, and then the perineal membrane. They will be in relation to the neck in case of the female. So this is the relation of the neck. Let us come to the relation of the superior surface, and this was the superior surface of the bladder. Okay, this superior surface of the bladder is here. Okay, so we come to the relation of the superior surface of the bladder. Now the superior surface is, as I said, it is completely covered by the peritoneum. It is completely covered by the, so only superior surface in the bladder is covered by the peritoneum, and this is in relation with the either sigmoid colon, and the coils of the terminal part of the ileum can rest onto the superior surface. So the coils of the small intestine and sometimes sigmoid colon, they may be in relation to the superior surface which is covered by peritoneum. Excuse me. Now, but in female, okay, this is also covered by peritoneum, okay, but that peritoneum is not going on to the posterior surface of the bladder, but it will directly go to the isthmus of the ureter, okay, and will form a small pouch, not as deep as rectovesical pouch, but a small pouch in female will form, and that pouch where the peritoneum is reflecting from bladder to the uterus is called as the vesico-uterine pouch. That pouch is shallow pouch is called as the vesico-uterine, just note down, vesico-uterine pouch. That means from superior surface directly to the isthmus of the uterus it will be reflecting, uterus, okay. So vesico-uterine pouch. Okay, let us come to the two remaining surfaces. These are infralateral surface. This surface, infralateral, right, and the left infralateral surfaces. Now they are as not covered by that of the peritoneum, okay, on the right as well as on the left surfaces, okay. Now these are separated by the superior surface. From superior surface, this right and left left infralateral and the right infralateral surfaces, they are separated by the from the superior surface by the lateral border, okay. They are surfaces by the lateral borders. Now in male, this infralateral surface, either it is right side or left side, it is related to the pubic bone. See here, it is pubic bone, okay. So it is pubic symphysis which will form the pubic bone on lateral side. So first it is related to that of the posterior surface of the pubic bone, and then there is a presence of a ligament which I will just tell you, puboprostatic ligament, and then there is a retropubic fat is here available. So the pubic bone, retropubic fat, in which the ligament, puboprostatic ligaments are present in case of the male, okay, and retropubic fat, as I said, is there, and then there are levator ani muscles. So infralateral surface is in relation with the levator ani muscle, which forms the pelvic diaphragm, or okay, it closes the pelvic cavity from below. So this surface is also in relation to the levator ani, and above the levator ani, it is in the part of it is also in relation to the obturator internus. So just I will once again tell you the relations of the infralateral surface. It is pubic posterior surface of the pubic symphysis, pubic bone number 2, then retropubic fat will be there, and then the puboprostatic ligament will be there, the levator ani and the obturator internus muscle, they are in relation to the both the surfaces, right and left infralateral surfaces. But in case of female, okay, since there is no puboprostatic ligament, okay, so this ligament is replaced by the pubovesical ligament, okay, the pubovesical ligament, it will be related, okay. So exactly that was going from pubic bone towards that of the prostate. So puboprostatic, it will go to the base of or the neck of the urinary bladder, hence called as pubovesical ligaments, okay. But when bladder is fluid, these all relations and surfaces and borders, as I said, are true when it is empty and it is tetrahedral in shape, where almost every surface is triangular in shape. The whole organ is triangular, okay, in shape. That's why tetrahedral. But when it is full, then this infralateral surface becomes the anterior surfaces, okay. And this is not covered by the peritoneum. Okay, so it, I mean, say expand towards the, or it pushes the peritoneal cavity upwards towards the umbilicus. Okay, and it becomes an abdominal organ. Okay, because it becomes a large oval shaped structure. Right, I think this completes the relations of the urinary bladder. Okay, relations of the urinary bladder. Let us come to the, which was the next point. Yes, in relation we will also learn about the these ligaments. Okay, I will tell you about the ligaments. So let us see this diagram of the ligaments. Ligaments of the bladder. This is just a rough transverse section of the pelvic cavity at the level of the neck of the bladder. So this is the urethral opening, I mean say sphincteric opening, and this is the base of the urinary bladder. Okay, our neck is here, not base, I'm sorry, not base, but it is the neck of the urinary bladder is here, lower end of the urinary bladder. And here I have shown you the various ligament through which it is attached. Okay, the bladder is attached to the peripheral structure, that is the pelvic cavity, and it is support. Thus this ligament forms the support of the urinary bladder. So there may be a short note like that, right, about the supports of the urinary bladder. Now, important support of the urinary bladder is the median umbilical ligament, okay, which we have learned from apex to the umbilicus. This also holds the bladder in position. Okay, it forms important supports. The median umbilical ligament is there. Then puboprostatic ligament. See this puboprostatic. This is in case of females. Okay, so this is pubovesicle is here, but in case of male, the same ligament coming from posterior aspect of the pubic bone. Okay, this is pubic symphysis and this is the pubic bone. This is the posterior surface. Here will be the sacrum will be here. So this is the pubovesicle in female and puboprostatic in case of the male ligament. Same place. Okay, will be there. And then it is the another ligament is the lateral ligament, and this lateral ligament extends from the lateral aspect of the neck of the urinary bladder, that is lowermost part of the urinary bladder, and goes to that tendinous arch, okay, which gives origin to the levator ani. So this will go here and gets attached to the fibrous fascia, okay, arch, tendinous, I mean say fibrous arch. Okay, it will get attachment onto the lateral wall of the pelvic cavity. Okay, so that is called as the lateral ligament. Okay, and then there are the pair of the posterior ligament which will go to the pelvic wall. Okay, pelvic. So these are the fibromuscular, not only fibrous, but they also contain some muscles, smooth muscle. Fibromuscular attachment, I mean say ligaments they are, and they give attachment to the neck of the bladder, okay, to the surrounding pelvic wall. So pubovesicle, lateral ligament and posterior ligament, 3 on one side and 3 on other side, and then the median umbilical ligament is there, both in case of male and the female. Okay, let us come to the blood supply, okay, of the bladder. Okay, when we see the blood supply of the bladder, we'll see that it is supplied by the 2 arteries. Which are those 2 arteries? Superior and inferior vesical artery. Okay, in one of the video I have told you the branches of the internal iliac artery. Okay, it's anterior division and posterior division. So the superior and inferior vesical artery are the branch of anterior division of the internal. They are the major source for blood to the urinary bladder. But then small branches, they also come from the obturator artery, which is running in the lateral wall of the pelvis, going towards the obturator canal to come out. Okay, so obturator artery, while it is running in the pelvic cavity, it also gives some branches to the urinary bladder. And some branches may also come from inferior gluteal artery. So there are 4 arteries, 2 major and 2 minor, that is superior and inferior vesicle. They are major blood supply, while obturator and inferior gluteal artery branches, they are the minor. I would say a small area is also supplied by this. Okay. In females, there is an additional source beside this, okay, and this is from uterine and vaginal artery. So in female, there will be the uterine and vaginal artery may also go to the bladder. I mean, so they go to the bladder to supply the urinary bladder. So in female, this is an additional supply, that is uterine and vaginal arteries. Branches coming out of the uterine and vaginal artery. Let us come to the venous drainage of the urinary bladder. The veins form a vesico-venous plexus. That means a plexus of vein is formed on the base, okay, of the bladder as well as near the neck. Near the neck and the base, there is a base matlab posterior, okay, posterior surface. Okay, there is a venous plexus is formed, okay, and this venous plexus is called the vesico-venous plexus. Vesico means urinary bladder. Vesico-venous plexus, and from this venous plexus, the veins, they drain into the internal iliac vein. So it drains ultimately to the internal iliac vein. Now coming to the lymphatic drainage of the urinary bladder, this goes to the external iliac nodes, okay. Most of it goes to the external iliac node, though it is not getting any blood supply from external iliac artery, but lymphatics are going to the lymph nodes which are arranged on the surface of the external iliac artery, so or vein, okay, to the external iliac node. But then this also go to the internal iliac nodes, okay, external and internal iliac node, where ultimately the urinary bladder drains its lymph. Now supply, okay, now supply. I will take some more time to explain the now supply because it is very important. The now supply is from the inferior hypogastric plexus, okay. Inferior hypogastric plexus will send its autonomous now, that is the sympathetic and parasympathetic, to that of the vesical plexus, okay, to that of the vesical plexus. Let us understand in little detail because it will be used for the, I mean to say, I will just tell you about this parasympathetic fibers, okay, just with the help of this diagram, okay. I will tell you the nerve supply which comes from the, since it is a viscera, it has to be supplied by the autonomic nerves, that is sympathetic, and the parasympathetic nerve, okay. So let us see first how the parasympathetic nerve comes. The parasympathetic center is located between S2 and S4 spinal segment. So this is the spinal cord. Say example, it is situated between S2 and S4 segment, sacral segment. And this is the lateral horn where the preganglionic parasympathetic neurons are located. They send the presynaptic or the preganglionic fibers which comes, and then it supplies here, okay. This is the vesical plexus, okay, through the pelvic splanchnic plexus. It will ultimately come to the vesical plexus, which is by the side of the bladder, and here there are the set of the neuron, that the postganglionic neurons are located of parasympathetic, and then from the axon arising from that, okay, this plexus, vesical plexus, it will supply to the muscle of the bladder, and muscle of the bladder is a detrusor muscle, a smooth muscle, arranged in a different fashion, so that its contraction will lead ultimately to the evacuation of the urine from the bladder. So it is neither arranged in longitudinal or circular fold, but it is forming the various whorls like structure, so that ultimately contraction forces the urine to go out, okay. So this is the preganglionic fiber, and this is the postganglionic fiber of parasympathetic coming from the segmental level of the sacral segment of the spinal cord, and then this is supplying to the detrusor muscle. Stimulation of this parasympathetic fiber leads to the contraction of the this smooth muscle of the urinary bladder. Okay, and then this fiber from this plexus, vesical plexus, is also going here to the internal urethral sphincter, which is present at the neck. A smooth muscle, circular band of the smooth muscle present at the neck of the bladder, which was the sphincter, okay, internal sphincter. But here this act as a relaxant, okay. The both are smooth muscle in the wall of the bladder as well as at the sphincter. But the function of this parasympathetic is different. Here it leads to the contraction of the bladder, but here it leads to the relaxation of the smooth muscle so that the sphincter opens up and the urine passes. So there is a pressure of the contraction and then the relaxation of the internal sphincter ultimately leads to the micturition. Okay, so it means the parasympathetic fibers, they ultimately helps in the process of the micturition. Okay, and this area between our neurons, parasympathetic neurons located between S2 to the S4 segment of spinal cord are called as the lower center of micturition. This is called as lower because it leads to the passage of the urine, okay, into the urethra. Right, but then it is also supplied by the sympathetic fibers, and sympathetic fibers, they come from T11 to L2 spinal segment, T11, T12, L1 and L2 spinal segment, and here the preganglionic neuron or preganglionic neuron is located, a sympathetic neuron is located in the lateral horn of the gray matter here of the thoracic and the upper lumbar spinal cord, and these preganglionic fibers, they come to the vesical plexus here again, and then the postganglionic fibers, they arise from this vesical plexus and they go ultimately to that of the urinary bladder. Okay, it goes to the muscle of the urinary bladder where they have a negative, this action. What does it mean, the negative, as I have written here? They relaxes the smooth muscle, and then they also supply the internal sphincter where they constrict the internal sphincter. What does it mean? When the bladder is relaxed, urine keep on collecting inside it, okay, and since the sphincter is closed because of the sympathetic activity, then the urine cannot pass. So the sympathetic function is to fill the bladder, while parasympathetic function is to evacuate the bladder. Okay, so one is filling, okay, and then when parasympathetic stimulation comes, when bladder is full, the signals from the wall of the stretch receptor wall of the bladder will go to this lower center, and then it will lead to the micturition. So this is how the sympathetic and parasympathetic, they are innervating, okay, to the bladder. But then this is not only the control and mechanism of the micturition. There is another fiber which is coming from the S2 and S4 level, but it is a somatic fiber, so motor fiber, somatic, and this is coming from S2 to the S4 in the form of the pudendal nerve, okay, and this pudendal nerve goes and supply to the this sphincter urethrae, which is made up of the skeletal muscle. So a person can have the voluntary control also on the passage of the urine, okay, though he is having the desire to go and for the passing the urine or to micturate, but he can have a voluntary control for some time, okay, so that, okay, whenever he will get the suitable place to micturate, he will go to the toilet or washroom and then do it, okay. Till then he can hold through this voluntary control of the pudendal nerve, okay, which is coming from the anterior horn of the gray matter of the spinal cord. So autonomic as well as the somatic nerve control is there. Let us see first to the micturition mechanism. Okay, the higher center for micturition, which is under your voluntary control, is located in the paracentral lobule on the medial surface of the cerebral hemisphere, okay, and fibers from this higher center of the micturition comes to this S2 to S4 level, where the lower center of micturition is located. Okay, and as we know that both the parasympathetic fibers going to the wall of the bladder as well as going to the internal sphincter, both are made up of smooth muscle, are innervated by parasympathetic. But we have seen that the pudendal nerve is also supplying to the external sphincter, okay, sphincter urethrae, okay, which is the skeletal muscle under your voluntary control. So both the controls are here. Now, how the mechanism of micturition begins is that when the bladder is full, around 300 milliliter is there, the person feels a little pain and desire to micturate because of the stretch receptors present in the wall of the urinary bladder. This stimulates the stretch receptor sensation. They go up to the lower center, okay, lower micturition center at S2 and S4 spinal level, and this stimulates the parasympathetic motor activity, which will lead to the contraction of those smooth muscle in the wall. At the same time, these parasympathetic fibers are going to the internal sphincter and it will relax the internal. So the micturition will take place. The urine will pass. Okay. And at the same time, through the voluntary control, okay, of this upper motor neuron, and this is the lower motor neuron control here, okay, this sphincter will also relax, okay, at the same time, okay. So it is the voluntary control as well as autonomic control is here, and ultimately the micturition takes place. Now when we come to the applied importance, this mechanism will help to understand us, okay, will help to. The lecture is going a little longer, but please, okay, just 5 more minutes and then we will complete the last point of this question, and that is the applied importance. Let us see the applied importance, other than we will come to the micturition mechanism. Now, because if there is an enlarged prostate, this will lead to the obstruction in the passage, because urine has to go through the prostatic urethra, and in the old age the prostate get enlarged, and because of this there will be urinary bladder has to force, okay, contract vigorously to pass the urine, and because of that the muscle of the wall of the bladder will become, bulge out in the mucous membrane, and if you will see inside the bladder cavity, okay, there will be trabeculated or ridges will be seen, okay. This indicate that the activity of this muscle is more, okay, because there is a blockage at the level, okay, of the prostate. To overcome this blockage, the bladder has to contract vigorously. So this will lead to what is called as trabeculated bladder. Now the second applied importance is the suprapubic cystotomy. Cystotomy means cutting of the urinary bladder, and suprapubic, then for this, that is a easy approach to remove the stone from the bladder, okay, or to do some surgery inside the bladder, okay, or to remove the prostate, okay, from this route, okay, because prostate is just at the neck of the bladder, okay. This approach, that is going through the cavity of the bladder, is taken, and for that the bladder is distended by putting the fluid so that it becomes an abdominal organ, okay, because it goes up towards the umbilicus, and then the incision is given, suprapubic incision is given, and it is given in the bladder so that the surgeon can enter inside the bladder from this route, okay, without interfering this peritoneum, because peritoneum is reflected on the superior surface. See here, this was the peritoneum is here, this blue color, it is reflected on, and when the bladder will enlarge, okay, this surface, infralateral surface, can be cut here, okay, when it will become an abdominal organ without interfering with that of the peritoneal cavity. Then third is applied importance is stone formation in bladder, because the urine remains here for a long time, for few hours, okay, and the get concentrated, so that say it is concentrated urine, so stone may form here in the bladder. Okay. Now we come to the last applied importance, micturition mechanism. I have just told you about the micturition mechanism here. See this mechanism, I have told you about the mechanism of the micturition, how it has the autonomic and that is sympathetic and parasympathetic control, as well as the voluntary control of the micturition. Okay, so the micturition is a reflex action controlled by the micturition center located lower micturition center located at S2 to S4s, okay, spinals. Though this reflex is mediated through motor and sensory parasympathetic, okay, it is mediated through the motor and sensory parasympathetic activities, but it has always the voluntary control, as I have just explained you, through the pudendal nerve. It has a sympathetic and parasympathetic. Over the sympathetic, it has a somatic control also. Okay, same time. So this reflex is controlled by the cerebral cortex through the upper motor neuron. What was the upper motor neuron? Coming from the higher center of micturition in the paracentral lobule or medial surface of cerebrum. This is the neuron which is called as upper motor neuron control. Over this neuron, which is at the sacral level of the spinal cord, which is controlling the external sphincter. This is the lower motor. Unless and until the control is not from the upper motor, lower motor neuron will not do anything. Okay, so this is the main control of the upper motor neuron. And if this control is cut here somewhere, that means if there is an injury to the spinal cord, there is a transaction of the spinal cord above the level of the S2 to S4, that means above the lower center, if it is cut somewhere in the upper lumbar or the thoracic region spinal cord, okay, then this control, what was the control exerted by the upper motor neuron through the pyramidal tract? It can voluntarily inhibit the micturition. Till you don't want, you cannot pass the urine. Okay, this you are holding your urine voluntary, and this by this upper motor neuron through the upper micturition center in the paracentral lobule, you are giving order to that now the micturition should start. So initiation of the act of micturition and the holding of the micturition is the control which is under your control. Okay, that means it is a somatic activity. Okay, over the autonomic hour, that is over this parasympathetic lower center. Okay, now if there is a, as I said them, there is a defect or there is a transaction of the spinal cord above the lower central, that means there is no control of the upper center over that of lower center, because the upper motor neuron fibers which were coming through the pyramidal tract, now they are cut. Okay, so you have no voluntary control over the micturition process, and this can be in two different way. Okay, into when the upper central control is gone. Okay, number one, where only upper central control level is gone, that means transaction of spinal cord injury is at the lumbar or the spinal, thoracic level. Then the micturition will become an automatic reflex bladder. That means it is due to the transaction of the spinal cord above the lower micturition center, which is located at S2 and S4, and the control of higher central is lost, as I have explained you. Okay, so that means inhibition of the micturition, you cannot inhibit voluntarily. Okay, you have no control, it will pass, urine will pass without your control, and then you cannot have the initiation of micturition. Thus the bladder, when it will become full, okay, more than 250 milliliters, say for example, stretch reflex will go to the lower center, to the S2 to the S4 segment, where they will stimulate the parasympathetic neuron, preganglionic, which will ultimately send signal or impulses. So the bladder will contract and the internal sphincter will relax. So the urine will pass automatically. Okay, that's why it is called as automatic reflex bladder. But if the center, the lower center itself is destroyed, that means the spinal cord is injured at the level of S2 to the S4, okay, if it is destroyed, this center itself is destroyed, that this reflex, automatic reflex bladder will also not be there, okay. Then it will just become a simple bag of the muscle. Urinary bladder will is nothing but is without any control, okay, but neither somatic, neither autonomic control is there. And this is just a bag in which the urine is continuously coming, filling the bladder, and then when the urine become in large quantity, it will start dribbling, okay. Drop by drop it will keep on coming, okay, it will keep on coming. Now in this, as I said, in this situation, bladder will fill completely, and then the urine will keep on dribbling continuously, as there is no control at all, no reflex activity, okay, no voluntary control. And this kind of, when the patient is passing the urine continuously drop by drop, this is called as autonomous bladder. It is. This completes the, answer on the question of a long question on the urinary bladder, including its nerve supply and its applied importance. Thank you very much for watching this long.